Hello, hello, Mahesh. All right, Mahesh. Mahesh, Mahesh Pillai, you had a hard time coming in. Can you let me know about that? Are you there, Mahesh Pillai? Can you hear me, Mahesh? Ariel, can anybody hear me? Is anybody in here? Okay, I may need to close this Zoom and start another one. If anyone's interested. Is anyone interested in coming to the webcast here? Because we seem to be having trouble getting people in. Mm. Okay. Okay, you can hear me. You can Simon. Okay, Simon Beta. Okay, you're in the panel. Okay, you're already in, Simon. A couple of people having a hard time coming in, and I'm kind of wondering if it's a low bandwidth issue or not. But you guys get in. Oh, that's good. I think Zoom is making it so that unless you have a decent bandwidth, they're not going to let you in. Oh, okay. Good morning, Dr. Winkler. Can you guys hear me? Can anybody hear me?
Hi.
Hello.
Hello, Dr. Bennett.
Yes.
Hello, how are you doing?
Good. I can't see your screen there.
Yeah.
Okay, let me get all. I'm pinning it. Okay, there we go.
Unfortunately, I'm not in Munich or in Salzburg. I'm in countryside, so I use my iPhone. I apologize. This minimal standard.
Okay.
But in advance, first of all, I thank you so much for your impetus and for your turgor. We call them in Latin, for your energy and power to organize this neurosurgical TV. It's a great story, a great project.
Thank you. It's a continuing story.
Yeah.
And you guys are going to help us continue.
Of course. So I, first of all, so if we have 2 minutes time, I just explain you about myself. So I retired from my position as chairman and professor in Salzburg. And before I was in Munich, and a long time ago at Cleveland Clinic for my fellowship in epilepsy surgery. And by the way, my great hobby is neuroanatomy, functional neuroanatomy at a certain really high level. So let's say my great hero is Henri Duvenois. Henri died a couple of weeks ago in Besançon, in France. Maybe I'm sure that you know his books about brainstem vessels, venous drainage of the cerebrum. And that's the background why I stimulated Santino Tomasi, one of my pupils, to continue with anatomy. I myself will also continue with neuroanatomy. I was invited as a guest professor at the Charité in Berlin Hospital, University Hospital, and I will establish my own laboratory in Munich. So where I'm from Italy, northern Italy, but I was for a long time, I spent in Munich. So that is the story behind why I'm here. And I want to help my pupil, Santino Tomasi, and you, and the other people in the community to push forward the things. And we'll organize many courses in Europe and in Germany. They in Germany consider me as a kind of reference figure for neuroanatomy. Let's say a small rotom.
Oh, good. Yeah, I talked to Juha, said hello yesterday. He may come. Juha.
Yeah.
Yeah, he knows you. Yeah, he said, yeah, I know Peter. Yeah, I know Peter. He's He's retiring. I said, yeah. He's going to talk about that. And so he said he's going to try to come.
Yeah, great. Fantastic.
Yeah. So that's great. You can access from a smartphone, huh? You're in the rural area?
Yeah, I am in Bamberg. Bamberg is between Munich, Frankfurt. We have a house here in countryside, and I have to reorganize the big garden here in the green, and that's the reason why for the next meetings I will participate. Of course, I will offer you an excellent infrastructure, my laptop and etc. So on. Also, maybe to show some information, some slides.
Yeah, we want to connect with you, and we can do many webcasts. This will be just the first, and we certainly want to explore what you guys are doing, what the community's doing, especially with things like augmented reality and new technologies. As you know, they're affecting everything. So
thank you so much for your
well, it's different, Dr. Winkler, this wasn't there when I was starting. Hello, Giuseppe. Okay, let me unmute you there.
Can you hear me?
Yeah, I can say John Bennett. Nice to meet you.
Nice to meet you too.
Dr. Winkler's here. He's using his smartphone. He's in a rural area. Hello, Dr. Winkler. Say hello to Giuseppe. I'm sure you know him.
Hello, Dr. Umana.
Hello, Professor.
Hello, how are you doing?
I'm fine. I hope you too.
Sì, tutto bene, grazie mille, grazie.
Okay.
Just to speak a few words in our language, in Italian.
Yeah, it's similar to Spanish. I understand Spanish, but not Italian.
È fantastico vederla personalmente. Ma io uso il smartphone. I'm using a smartphone as I told to Professor Bennett. And for the next time, I will, because I'm in countryside, in a rural area, and our country house there.
Okay, excuse me, Giuseppe. I guess the way we'll structure it is I'll basically introduce myself and then introduce you, and you just run the show. Is that okay?
Okay, as you prefer.
Yeah, because you know the people and you know what you want to do. So you just run the show. You just run the show and do what you want to do.
Okay.
and there's no hurry. We got however much time you want, you can take.
I think that we are a bit early. And,
Yeah. 10 minutes. 10
Ottavio
minutes.
Tomasi is missing, also Paolo. And
I-
maybe Professor Yo or not.
Hello.
I see Gao. Oh, okay.
Hello.
Welcome, everybody.
Hello. Thank you.
Hi,
Yeah.
Dr. Tomasi.
Professor Winkler.
Hello.
Hello.
Tutto
Hello, how
bene?
are you?
You're
Sì.
Tutto
taking
bene,
over.
sì. Hi. Hello,
You're
tutto
taking
bene?
over the lab, right? You're taking over the lab, right?
Yeah. I hope I can continue what the Professor Winkler did, and we will work together too. So I'm sure we'll be good also with Dr. Umana, and yeah. We'll
Okay.
see.
Okay. So can you basically tell me, Giuseppe, what you're going to do, just so I know?
Well, I think that maybe Professor Winkler could start talking about his study that we published last year.
Okay.
And then also
Is he
Ottavio
going to
could-
have to? Is he going to have to screen share much? Because he's kind of limited. He's got a smartphone. Is he
Yeah, but I think that Ottavio could share something by computer, by laptop.
Okay. Oh, okay.
I can.
Oh, we have a little bandwidth there. Sent
Yeah.
little bandwidth
And
issue there.
also there are the colleagues from Singapore, Professor Yo, Dr. Gao, and Dr. Swati. We are starting a cooperation with them, and I think that their contribution will be a great importance for us.
Okay.
And they can talk about the project and our cooperation, our future projects.
Catania, Italy, right?
Catania, I come from Catania. Yeah, I live here.
Catania.
Yeah.
On the East Coast.
Yes, or the island. Yeah.
You know, I was thinking that I want to go to every state in Italy. How many states you have? Like 50, right? For 40, 50?
I think that 15. Ottavio, do you
Oh,
remember
only
how
15?
many? We are not a federal country. We are
you don't-
regions.
Oh, so you don't consider it a state? You consider
No,
a region?
no,
A
no,
region?
no.
A region?
Yes, yes. That
I was
are-
born in the most northern part, for
Yeah.
example, in the mountain area, in the German-speaking area. So we
Oh.
speak 3 languages in our area:
Okay.
Greco-Romanic, Italian, and German. So I'm the most northern, and Giuseppe Umana comes from the most south part, from Sicily.
Yeah.
Okay.
So it's a kind of very inhomogeneous and very interesting, fascinating country, of course.
Yes.
But tell me about your picture in the background, Professor Bennett. What is this Miami? No.
Yes, that's Miami. Yes, that's Miami Beach. Actually, let me pin it here. Yeah, this is a beautiful beach here.
Yeah.
In Miami Beach. Miami Beach is an island off Miami.
Yeah.
It's not it's part of Miami, but I mean it's separate geographically. Geographically.
Great. Interesting.
Yeah, they have a lot of conventions here. In Orlando, of course, Disney World.
Did you know Tom Neidig? When he was still in, Neidig, the neuroradiologist?
No.
He's in Mount Sinai in New York now.
Oh, okay. There's a
He
Mount
used to
Sinai
be-
here. Yeah, there's
He
a
was
Mount
in
Sinai
Miami,
here.
yes.
Yeah, he's probably at Mount Sinai in Miami. There's a Mount Sinai also in Miami.
Yeah. And of course, Jacques Marcos is still there, yeah?
Yeah,
In-
yes.
Marcos, yeah.
Yes, he has a lot of webcasts.
Yeah.
He has a funny webcast. Yeah.
I had personal contacts to him. He knows me very good, and we had a good contact when he was in Europe, traveling around Europe.
Oh, okay. And let me change my background here. Because we're not, see here.
You don't see me, yes? You don't see me.
No.
How can I arrange this? How can I arrange this? Oh.
What, the background?
No, you don't see my image, yeah? You don't.
Oh, I've got yeah, I'm getting off. I have a pin here. Okay. So you have the screen now if you want to use it.
Mm-hmm.
Because only one person can screen share at a time.
No.
Santino, you have pretty low bandwidth, Santino. I hope you don't have problems. You're not. Are you going to have to screen? Are you going to have to screen share, Santino?
I don't know if I work. I can try because I'm also with the phone. Then
I think you're going to have a hard time, Giuseppe. Santino's going to have a hard time screen sharing. I hope that he doesn't have to screen share, right?
I can try to send a file to Giuseppe because I'm trying to do that because I think
okay.
then we will have everyone with the file.
It's going to be
because
it's going to be impossible for you to screen share from that device. Mm-hmm.
Okay, send me your presentation and you can talk and I can click the
that's a good way to do it. That's a good way to do it.
Okay. We have 4 minutes to go.
Hi, Giuseppe. Yeah, I'm on. Yeah.
Greetings. Welcome.
Hi,
Welcome.
Hi, John. Hi.
Welcome to Neurosurgical TV.
Hi.
Thank you.
We are trying to fix this.
Okay.
Yeah, there's no hurry. We can start a few minutes late. Doesn't matter.
Just
Takashi. Can you hear me, Takashi? I guess he can't. He's a Japanese neurosurgeon. Hello, Takashi. Is your audio on? Maybe not. He's actually going to translate.
Hey.
Yeah, how you doing?
Good evening.
Yeah, welcome. This is Takashi Gawa. He's Takashi Khan. He's a neurosurgeon from Japan. He's going to be translating into Japanese.
Mm-hmm.
Thank you. Thank you very much.
Good evening. Good evening, everyone. So yeah, for Japanese neurosurgeons, younger neurosurgeons, I can translate into English to Japanese.
Great. Fantastic.
The way he does that is ingenious. He just uses another Zoom with a laptop. It's not an elaborate setup. Dr. Gao, you're translating in Chinese today?
No, actually, I'm invited by Dr. Giuseppe to speak regarding the Holo medicine program.
Oh, I'm sorry. Okay, great. Welcome.
Thank you.
Okay, everyone comes to the last minute. Letting everyone in. I wish Zoom would build it so you just let people in, but I guess they're having security issues, so they want you to admit every single person. Did you get the PowerPoint, Giuseppe? Did you get the presentation?
Not yet.
Is he the first, one of the first speakers or no?
I can start as a first speaker, and then they
Yeah,
can share
okay.
the screen, later stage.
We can do that.
Okay.
Okay, you ready to start?
Okay, I'm going to
Okay,
share
no,
my screen.
let me, no, wait, don't start yet. Let me introduce you
Okay.
first. Okay,
Okay.
10, we do it like television. 10, 9,
Okay.
8, 7, 6,
Okay.
5, 4, 3, 2, 1. Good morning, it's Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have a great webcast, Neurosurgery and Augmented Reality, with Giuseppe Umana and Peter Winkler and others that Giuseppe is going to introduce. And I'll just turn the proceedings over to Giuseppe. Welcome, Giuseppe.
Welcome. Hi, Dr. Bennett.
Okay,
So,
it's all yours, Giuseppe.
okay. Good morning, everyone. Today we are talking about neuroanatomy and augmented reality. Let me introduce you to Professor Winkler from Salzburg and Ottavio Tomasi, that is a learner. I'm Giuseppe Umana. I came from Catania. I work at Canizar Hospital. And we are cooperating with a great team in Singapore. We are three colleagues from Singapore that are Professor Yo, Dr. Swati, and Dr. Gao. I met the team in Singapore thanks to the Holo Medicine Association that I joined a few months ago, working about augmented reality. So I think that this is a good chance to meet other teams in other groups. So we could start with my presentation, then we could go with the other colleagues that will present their projects and their studies, okay?
Yes, fine.
Okay, let me share my presentation. Okay.
Yes, we see it.
Okay.
Perfect.
Okay. Fine. Well, I started cooperating with Popular in 2018, but I actually get the device only 8 months ago. And a few months ago, Circo Peltz, that is the CEO of Popular, founded the Holo Medicine Association. And since then, I think that all the process is going very, very fast and in a very interesting way. Later, also, Dr. Palmisciano will talk about his vision about new technology as a junior researcher together with Dr. Swati. Before talking about neuroanatomy, that I think that is a field that belongs to Professor Winkler, I introduce a bit of interesting applications of augmented reality in neurosurgery. In the last 8 months, we tested this device for many uses. Let's start. We started with the tumor patients. We did not know this device, so the first concern for us was to test and validate its accuracy. So we started comparing the accuracy of the device with the standard neuronavigation. In this short video, you can take a look at the monitor of the neuronavigator, and also the navigation with the hologram. The hologram is overlapped over the head of the patient, and the pointer is checking the accuracy with the standard navigation too. And the matching was fine. The only issue is that it's a manual procedure, so it's operator dependent. And this is the main limitation about Professor Yo is working also with us to try to overcome this limitation and get an automatic overlapping. Also, the meeting at Popular is working on that. Of course, the rendering are very interesting and very immersive in the anatomy of the patient. And these first feelings were very good to us. So we continued. And we tried to test this technology also for new devices, also for patents. So we started with a very simple device for EVD placement that is a standard procedure, very common and very important because it's life-saving in many situations. We worked a lot about this and we merged all the technologies that we got. So we tried to reconstruct the anatomy with the hologram. We tried to use also a plaster model, and we used also the standard navigation too. At the end of the study, we found that the accuracy was again good, was reliable. And again, the only limitation was the automatic overlapping. The device seems to work pretty fine, but we have to continue to test it also with cadavers and in the later stage with patients with clinical trials too. So this is important because in only a few months we tested this device in several situations. Also about trauma, that is a common pathology that we have to face as neurosurgeons. This is a young patient with a head trauma. We did an emergent decompressive craniectomy. And then we have to reconstruct the head of the patient, as we usually do with the standard technology that require to perform a 3D CT scan of the head to reconstruct a prosthesis that usually is performed with several materials, titanium, with PIC, with the custom bone, etc. We had also a lot of fun trying to navigate the prosthesis. So we performed a CT scan of the prosthesis. This is the phantom model of the prosthesis. So we did some tests and we tried to fix the prosthesis to perform the CT scan. In the early stages, we tried to fix the prosthesis inside plastic glass, but this cannot work because the CT scan did not separate the prosthesis from the plastic glass. So we tested it over and over again, and we found that with the silk wire, we could isolate the prosthesis. The final result is interesting, I think. This is an intraoperative vision of the patient with the real phantom prosthesis in blue. And this is in white. This is the prosthesis fixed to the head of the patient. In this video, you can see all the process that we have done during the planning phase, the planning stage. You can see this model. You can see the holographic prosthesis that can be overlapped similarly to the real one, the blue one. The matching also in this case is similar and is acceptable. Another tool that we developed thanks to the help of Liliana Duarte and Circo Pels and their team is the chance to lock the object during surgery, because in the early stages the hologram cannot be fixed, and so you could move it accidentally during surgery. So we worked on that, and we get this tool to lock that allow to lock the hologram. This is the final rendering and during follow-up, showing a good reconstruction with the custom bone prosthesis. This is also the reconstruction with the visualization of the muscle. And this is the standard CT scan. I showing these 3 images just to discuss a bit about this, because in daily practice, we need just a CT scan. And we know that the prosthesis is correctly positioned, that we have no complications. But if we can visualize a bit more, we have more information. And this is useful for everybody. And also for the patient, because it's not that easy to understand for a patient what is happening to them. In this way, they can have an immersive experience and fully understand what surgical program has been performed. Spine surgery was the first big project that we have done. We tried to attend the Congress in New York, and it was a great opportunity for us. We presented a very complex spine failure. She was a very fragile patient with previous surgery for low-grade brain glioma. Then she developed an infection of the wound of the skull flap. So she performed a craniectomy. And after a few months, she developed cervical spondylolisthesis. So she was treated at another institution for all these surgeries, including this cervical spine fixation. Unfortunately, the patient was very fragile. The bone was very poor. She did not attend all the follow-up meetings, so she was maybe lost during follow-up. And after 6 months, she was not able to walk again due to this spinal cord compression. So our task was pretty hard. So we did cervical corpectomy, a revision of surgery. Unfortunately, we did also a failure. And so we needed to treat again the patient. So this was the 5th surgery for this patient. And we wanted that it will be the last one. So we tried to study very well all the procedure. We planned a 2-staged procedure, anterior and posterior. The anterior procedure consisted in the removal of the old cage, in the positioning of a bigger cage, accomplishing a 4-level corpectomy, including T1. We did this with the standard anterior approach without any sternotomy. And we planned a staged posterior fixation because the patient was too fragile and cannot allow to us to perform a very long surgery. During the planning stage, we tried to get more familiarity with her anatomy. We did this also with the holographic model. We used this also to show this complex spine situation to the patients and family, because as you can understand, also the patient and her family were not happy of the old procedure that were always complicated by some complications, by some issue. And I think that the hologram maybe helped them to better understand our goal, and also which are the risks, which are the possible complications. In this other video, we have the holographic reconstruction of the CT scan, again, to get more familiarity with their situation that was pretty complex. These images are very nice, very interesting, but we have to use this technology not because the images are nice, but because they have to help us with our clinical project. This is an intraoperative use of the hologram with the overlapping of the CT scan of the bone 3D bone rendering. One use could be the one to define the level. We did this merging also with the intraoperative imaging with the X-ray, simple X-ray, or also with the 3D reconstruction of intraoperative images. Again, in this also in this patient, the only limitation was represented by the manual overlapping of the hologram. But again, we are working on that, and I'm sure that we will overcome about this, and we will talk about this with the Professor Yo. This is the final result that is fine. Offshore cannot be the best that we could get, but in consideration of all the surgery performed, in consideration also of the general condition of the patient, I think that is the best that we could get. And also we got a second position to the Congress. It is a good result for us. And I want to share this achievement not to show how proud we could be, but to encourage other junior colleagues to use new technology, because can allow us junior surgeons, junior researchers to join also to important events and get some result. Well, I'm finished. I think that we could talk with the team of Singapore that can share their experience and their projects. We are going to start a project together with an MRI tool, but I think that Professor Yo can talk about this. Okay, and later Professor Winkler and Ottavio can talk about neuroanatomy. So I can share the screen for Ottavio. Ottavio can talk, okay? So Professor Yo, it's all you.
Okay, thank you. I think I'll get Swati, who has the slides, to maybe do the presentation, and then I could just round up at the end, just to show what we have done. It's quite similar to what you've done, but we'll let Swati take the limelight. Yeah.
Thank you, Prof, for giving me the opportunity. Dr. Giuseppe, thank you for inviting the team from Singapore. I think I've been working with Prof. Niam and Yujia from the Department of Surgery for HoloLens, and we have been quite fortunate to have the opportunity to use HoloLens in the neurosurgery OR. And so far, our experience has been excellent, and we are hoping that with our collaboration, we can come up with newer projects to bring mixed reality right into the neurosurgery OR. So without delaying it further, I'll just bring through some of the cases that we have actually used HoloLens and our experience so far. Sorry. Okay. I think like it was alluded previously as well, I think intraoperative navigation is currently a very essential component of neurosurgical operations, but some of the major disadvantages that it's a 2D projection of images, and you have to constantly change your focus between the surgical field as well as the neuronavigation screen, and only the pre-registered instruments with the available neuronavigation system can be used. However, the recent progress in mixed reality technology has actually attempted to overcome these disadvantages, but so far the usage of mixed reality has mainly been in education, not so much in surgery. Very few studies are currently available to assess its accuracy. So I think we just wanted to bring how HoloLens looks like. I think we have seen in the previous slides as well. It's very portable. This is me wearing the HoloLens during one of the operations, which lasted for about 3 hours. And I would say it was very comfortable. And there was no surgeon fatigue at the end of it. And it was very easy to switch between the through the HoloLens what you see, or directly through your own eyes what you're looking at, where the surgical field is concerned. So let me just bring you through the cases right away. So the first case that we had was this very deep-seated extraaxial tumor right at the posterior forks. And a patient had previously actually undergone a resection already, and the histology was consistent with the atypical meningioma. And this recurrent lesion was actually growing in size. So we used the standard stuff S8 neuronavigation for intraoperative planning, and subsequently we rendered a 3D image using the HoloLens as well. And this was actually one of our very first cases where we attempted to see how accurate the rendering is and whether there's actually any correlation between the HoloLens and the standard neuronavigation that we use in the OR. So these are some of the very first pictures that I took. So this was before the draping. So I think we all know, even as residents, we often feel that it's very difficult to actually navigate, especially when the patient is in a prone position. But with HoloLens, it was very easy because all I had to do was use the pinna of the ear on bilaterally to actually try to get the image to come into, to be accurately projected onto the patient's head. And this is right after the patient was draped. And in fact, there was really not much drift that I thought happened after the patient was actually draped. I was wearing the HoloLens throughout between and after draping the patient as well. So I'll bring you through the video. This is the very first video that we took. So here is my colleague who's actually holding the probe. And as you can see, he's actually pointing at the tumor using the probe, and it actually correlates where I am actually looking at through the HoloLens where the tumor is actually located. And we thought it was very interesting that the accuracy was so accurate because this was just a 1.5 centimeter lesion, and we felt that we can actually explore the accuracy of HoloLens much further. So I think the surface marking, the issue definitely was that the surface matching was definitely relatively subjective. And we were worried whether after draping there would be a loss of surface marking. But because this was one of our very first cases and we are still trying to troubleshoot that part of it. So this was one of the first disadvantages we thought of the HoloLens. But overall, the experience was very interesting to use it, especially during the operation. This was relatively on the surface meningioma, just left frontal convexity meningioma, relatively large. And we thought it would be interesting to see how things look like, especially for the junior residents, whether it actually helps to delineate the anatomy a bit better. As you can see, this was projected before the patient was draped. Very nice, can see the contour of the meningioma very nicely. I didn't take any images where I tried to see if there was an accuracy between the stealth marking the anterior and the posterior margins of the tumor, but basically it was about the same as to what I expected on the HoloLens as well. This was right after draping, so I will show you some of the when I used the slicer to actually cut through, and this is my colleague actually using the probe again to mark the anterior border of the tumor. And it was really very nice because you can actually see the, if I just bring you back a bit, you can actually see the venous structures around it very, very clearly. And HoloLens even allows you to adjust the contrast. So whether you want the tumor to be highlighted or you want the blood vessels around on the contrasted scan to be highlighted, it's actually very, very easy doing that as well. The last case that we actually tried, in which we actually used Prof. Michael Shugru's software, the Omniscient software, which is basically an AI-based connectomics to actually look at the white fiber matter tracks. This is still in the pipeline, but it's one of our very first cases to see if even the white matter tracks can actually be projected using the HoloLens, and whether that further improves surgical planning. And this was basically a metastatic lung lesion, relatively very large. And we just wanted to see where the corticospinal tracts are being projected. So we actually used Prof. Michael Shugru's software in this case, and this is what was projected on the stuff. So you can see that the CSTs are actually draped right around the tumor, except for a very small window where there was no tracks involved. And we thought we will use this as the point of entry to prevent any further damage to the CST. And this is in line with keeping with the neuro-oncological functional balance to actually achieve maximal resection while preserving neuro-oncological outcomes. And like I said, we are working with him using his software. And the main aim of this case was to see whether we can render these tracks, which use the AR technology to allow the surgeon for real-time visualization during tumoral resection. Just some images that we have actually taken from his slides and his software. So basically, you can project the sensory motor tracks, the language tracks, as well as the visual tracks, depending upon where the location of the tumor is. And it's a AI-based software, and as you can see, the number of permutations that actually go through to result in those tracks. This was what we projected first through the HoloLens to see how the tracks actually look like. So we thought it actually looks like a cauliflower, but actually when you project it onto the patient with the MRT very nicely, you can see the small window of opportunity that we have to prevent any further destruction of the tracks during the tumor resection. But again, a very nice rendering of the image. You can further adjust the contrast, and we are also working with VSI and Microsoft to see whether we can get color rendering of these tracks. And just some more intra-op images after the patient had been dripped. So similar experience again, very nice rendering, and relatively good accuracy was maintained even after draping. So as the title of today's talk also says, neuroanatomy and mixed reality. Like I previously said, I think it's very beautiful to look at the tumor as well as the MRI images, and the residents actually feel they can actually appreciate the anatomy a lot better in 3D than in 2D, with especially visualization of the vascular structures around the lesions. And we actually tried with the spine as well. We did have a lot of issues in terms of trying to do surface matching for the spine, because there's movement in the spine which cannot be accounted for once the patient has been positioned, as compared to what when the first scans were actually taken. But we feel that it's actually good, very good for anatomy learning as well. So you can see this was what the extracted CT image of the spine looked like. So I was trying to position using my hand, but I really did not get a very good positioning because of the shift in the patient's head when the patient was flexed for this procedure. But I think for the residents learning, it's a very, very good opportunity, because it's very nice to see the joints, the whole anatomy of the spine. And I think, like it was shown in the previous presentation, you can use the MR, you can use the CT, depending upon what kind of structures you're looking at. So this is just me trying to get it in line with the patient. But unfortunately, we felt for spine, a lot of work needs to be done. This was just, again, the same patient that I showed earlier. So again, if we go very slowly on this video, you can actually see how nicely the vascular structures are being projected. This is even better when we are talking about, for example, medial sphenoid ring meningiomas, and we want to look at the anatomy of the cavernous sinus, of the MCAs. I think it's very, very good for learning for the residents in particular. So we feel it actually provides a very exciting avenue to explore, especially in neuro-oncology surgery. But further work definitely needs to be done in establishing its accuracy when compared to the gold standard neuronavigation. I think I will hand over to Prof. Yo to further input and summarize the whole talk as well. Yeah.
Yeah. Okay. So thanks, Swati. I think that was an excellent summary of the work we've done. So we envisage and predict that in the future, this will replace all standard neuronavigation. I think it's much cheaper. It's a commercially available system. And we think that it can be used all the way from third world to first world countries. I think it's just a fraction the price, but there's a lot of work to do. And I think this is the real future of neurosurgery, because right now, we can't really see through the skull, and it's just wonderful wearing this device that, we have all the information. It's like a computer on your head, and you can really see through the entire brain and pathology even before you made the fifth incision. And that's what neurosurgeons want. So it's a work in progress, but it's very exciting. And I hope that within the next few years, we'll be able to sort of commercialize this product and make it something that is available for the whole world. So that's our vision with Microsoft. Thank you. Thank you.
So I
Okay.
think that Dr. Gao could join also. Could show together with Professor Yo their project with the MRI tool that we will join together with Professor Winkler in Salzburg and Dr. Tomasi.
Thanks, Giuseppe. So let me just share my screen. All right. So thanks again for inviting me for this talk. Just a caveat, I'm actually not a neurosurgeon. I'm actually a liver and transplant surgeon by training. But I happen to be leading the Holo medicine program over at the National University Hospital in Singapore. And this is how everything actually started for all of us. So just to give a very quick overview of the Holo medicine program that we have here in Singapore and some of the research areas that we're looking into, as well as international collaborations, including with Giuseppe in Italy. So the term Holo medicine came about because of the words hologram and medicine, and it really utilizes mixed reality devices that combines the advantages of both virtual reality and augmented reality to give us a full three-dimensional depth perception of a virtual world that's superimposed onto the real world. Right, so as Dr. Swati pointed out earlier, the device that we're using at the moment is the Microsoft HoloLens 2, and we've actually used it for quite a number of specialties. So neurosurgery has been our heaviest users and the one that's leading the charge in development in this area. But we have experimented with other specialties as well, including the picture you see on the left. We were trying to use this for a sarcoma case for a patient with a thigh sarcoma. The picture in the middle is for a patient who would undergo a surgery for a huge retrosternal thyroid that needed a median sternotomy. So they were using the HoloLens to do guidance during the surgery itself. And the image on the right is actually me doing some pre-planning for a liver transplant donor that we're going to operate on the week after. So same thing, right? The picture on the left, Swati has already shown you regarding the brain tumor. So some additional areas that we're working on include planning for radiation oncology. Right, so the picture in the middle that you can see is actually a colored DICOM that we have developed together with Circo's team at VSI and Epocla, right, to actually give you a three-dimensional visual representation of the radiation fields and the radiation planning data for patients going for radiotherapy. Right, so this was one of our first use cases for a patient with prostate cancer, right? But this ability and capability can actually be applied to any region of the body, including the brain, right? For patients who are going for radiation therapy, and we actually foresee that it has a big application in gamma knife planning as well. Right, and the picture on the right is actually one of our patients who was given the HoloLens and shown a rendering of her scan as a hologram before she went for the surgery. Right, so again, some of the use cases that we have used. One of the things that we have tried doing is actually to stream a laparoscopic feed from the camera system directly to the HoloLens. So the picture on the bottom right was actually one of my professors doing a liver resection using a three-dimensional laparoscopic system. And we actually managed to stream the 3D image from the laparoscopy camera directly to the HoloLens. Right, so one of the areas that we're potentially going to try out for neurosurgery is transsphenoidal surgeries, right, and where we can actually stream the feed directly from the camera to the HoloLens. And the other use case that we are going to explore for neurosurgery is also, of course, streaming a live feed from a microscope to the HoloLens with a three-dimensional representation. Right, so to really start a program on mixed reality in healthcare requires a lot of background development. So developing a framework and a roadmap for the whole program, including what is the short-term and long-term goals. Where do we see ourselves 5 years, 10 years down the road? What are the research and development areas that we are looking at? What are the short-term, long-term projects that we can embark on, as well as looking at the basic software architecture, including image transfer from the PAC system onto the HoloLens, transfer of patient data, medical data from the hospital server onto the HoloLens, and then the Microsoft Cloud for AI processing, including all the data security behind it, as well as the processor standards and guidelines regarding the use of mixed reality devices in the operating theater, eventually in the direct patient intervention role. And like what Prof has mentioned before, hopefully, this can replace the existing extremely bulky and extremely expensive image guidance machines that we have. So areas of ongoing research that we have now within the program, as well as with the neurosurgery team, and also areas that we are looking to develop together with Giuseppe's team include auto mapping, where we can actually lock the image of the hologram onto the patient itself. Right, computer vision based image analysis, right, deformity modeling, where we hope that the AI will one day be smart enough to compensate for actually movements of the tissue within the human body. Auto segmentation, natural language processing, things like full data integration, image mapping, as well as remote proctoring, where we can actually have remote assistance, for complex cases which we may require help from elsewhere. In the undergraduate part, we also have a program, right, that looks at the undergraduate education using mixed reality, and definitely neuroanatomy, like what Dr. Swati has mentioned, is part of this program. So it leverages on AI and machine learning for precision learning for the students. And we have actually embarked on this program and working on various projects, including the use of HoloLens for bedside teaching, for surgeries, where we can stream the surgery together with annotations from the operating theater to the students who may be at home and not able to enter the operating theater due to COVID restrictions. Basic science teaching, interactive guides, and these are all areas that we can potentially explore and work together on to develop for undergraduate teaching as well. So, that's my short introduction of the program we have here at the National University Hospital. So, we have had the pleasure of meeting, Giuseppe through the Holo Medicine network, and, as well as, through the association itself. And, we have had a few discussions with him to look at, potential areas that we can collaborate on. And, we are very excited to really work on this together. Thank you.
Thank you, Gao. I think that your program is very interesting. I would like to listen also to Paolo Palmisciano, that is one of our research fellow. He spent some time abroad in London and is aiming to reach the United States as a research fellow. So please, Paolo, could you share your idea about artificial intelligence, virtual reality, mixed reality, and your future project too?
Thank you very much, Giuseppe, for your introduction, and thank you to all the panelists for the amazing projects with who I will have the pleasure to work with. And thank you, Dr. Bennett, for the opportunity. So I have a little background in research in neurosurgery, mostly focused on AI and the application of innovative technologies, mostly to improve, as previously mentioned, undergraduate programs, teachings, and also patients' teachings about their condition. So in my opinion, as a young researcher and yet to start, hopefully in the future, residency in neurosurgery, I think from my experiences that AI and also augmented reality, mixed reality will be the future, but those won't be the blind future for all neurosurgery in the world. All of this, as previously mentioned by Professor Yao, needs to be more accurate, need to be proven to be useful in the clinical practice. So one of the projects I worked on was focused on understanding patients' attitudes about new technologies, specifically about AI. But in this case, I think AI and augmented reality have been so interconnected right now in the future that actually knowing patients' attitudes about AI and augmented reality would improve not only clinical practice, but also teachings, residents, or the future about neurosurgery. Because in my opinion, when we had, since the first year of residency, we need to focus on how to care to patients, how to explain patients their condition in order to have them trust us and trust in our surgery. We also need to understand their fears, their attitudes, what they fear of when they are doing neurosurgery. And most of all, we need to understand how they perceive new technologies, as important as augmented reality. So I think that by connecting through many different institutions around the globe with a unique focus on understanding AI, improve AI, trying to interconnect AI with augmented reality, we may push neurosurgery teachings and I think all kind of surgical specialties to another level, to the future, again, with the aim to improve patient care. So thank you for this opportunity and for your interesting ideas.
Thank you, Paolo. I totally agree with you. And again, thanks to Professor Yo and Dr. Gao and all the team of the Singapore hospital, the National University of Singapore. It is one of the most important universities in the world. I think that you are ranked 11th. Am I correct?
I'm not sure about that. We're not the first, but I'm not sure about our world rank. I think in Asia we are number 1, but I'm not sure about the world. Yeah,
it's a good result. So I think that we could leave the word to Professor Winkler and Ottavio Tomasi. I will share my screen with the presentation of Ottavio, so you can decide who will be the one to introduce the presentation. Professor Winkler, please.
Thank you very much, Giuseppe Umana, and I thank again John Bennett for organizing this fantastic meeting. I apologize, as I told you a couple of minutes ago, that I'm in countryside, and Santino Tomasi, my former co-worker, found me here in the green without internet. I have just my smartphone here. But I promise you that I'm very interested in the two presentations, even yours and from the group from Singapore, is incredibly stimulating to teach anatomy, to continue to learn and teach anatomy. I retired from Salzburg University in March, end of March this year. And I tell you that I'm reading books more than before. I go back to old books, to the oldest one, to the really old books from let's say in my opinion, greatest anatomist, neuroanatomist of all time. His name is Henri Duvernois. He died a couple of weeks ago at the age of 93 in Besançon in France. If you look at his books about brainstem vessels, drainage of brainstem, hippocampus, or the cortical anatomy, it's a gold mine. And if I have to review papers in neuroanatomy from the neurosurgical community, I know that if there is no citation of Henri Duvernois, I know exactly that this is not a paper worthy to be published. So let's say your work, it's great, it's fantastic, but it remembers me when the three-dimensional MRI came in the 90s. I was a young resident before I moved from Italy to Germany and then to Scandinavia. And this was a kind of wonder for us. And the same is now with your technique. Your technology is amazing. It's great. But the people who uses this technology has to be prepared in terms of knowledge, of really, really high sophisticated knowledge in neuroanatomy. And I told all my people, I told always, my former residents in Munich, Germany, and then also in Salzburg, please start in the laboratory. Neurosurgery starts in the laboratory, as one of our great pioneers, Professor Yassagil, showed us all the time. You have to dissect 400, 500 brains before you understand brain anatomy. So let's combine your fantastic technology and what I try hardly at the moment to combine all the knowledge we have, the books from Stephen Stilwell, Henri Duvernois, from Seger, from Albert Rotten, of course, from Yassa Gill, from Economo, Clara, etc. So on. There are about 40, 50 textbooks you have to read, you have to understand, and then let's combine this. But this is, of course, a very time-consuming story over years with your fantastic Holo technique. So I'm very enthusiastic about your technique. Congratulate you, Giuseppe Umana. I congratulate the friends from Singapore. And I thank again Professor John Bennett for organizing this fantastic meeting. And I apologize again, my very, very small technique. Smartphone. I promise you, the garden now is the garden in the countryside now. It's plus minus. It's organized. It's in the region of Bamberg, between Munich and Frankfurt. We have a house, and then I will be back to Munich in a couple of days. And there, my infrastructure, my technical infrastructure, of course, it will be okay. Thank you again, and have a nice Sunday. And I give back to Giuseppe Umana. Grazie mille, Giuseppe.
You're welcome, Professor. Ottavio, could you talk about this project that was started by Professor Winkler some year ago, and then we join it in a later stage?
Hello. Hey, thank you, Giuseppe. Thank you, everyone. So I hope you can hear me well. So yeah, just I want to spend 2 words about this work. So we did together with Professor Winkler, with you, with the other colleague. And then we can talk, of course, about this project regarding our lab, and then the combination with these fantastic new tools and technology like augmented reality and artificial intelligence. So if you want, I can just spend 2 words about the work, the paper, just because I think this is interesting to see. So this is just now we move to the past. So because after this futuristic presentation, excellent and very fantastic. So we have an old-fashioned study, if we can say so, about the importance of the cortical vein. And this is important in relation with the brain shift, because everyone knows the importance of the brain shift, especially you have to fight sometimes with the brain shift when you are in the operating room. We have a lot of tools. So then like the neuronavigation, of course, we use today also the routinely the ultrasound, the intraoperative ultrasound so far. But I think sometimes for us, it's difficult when we have a big brain shift, and then of course this is not possible to realize and to have a real-time picture of this situation if we would like to combine with the preoperative imaging. The study, this is interesting study, I think, about the importance of the cortical vein, the surface vein, as landmark for neurosurgical practice. And then, so we did that with a combination with the sequence T1 MPARAGE and with the 2D TOF angiography, because we can see respectively, so the cortical surface and the vein after injection of contrast. So in this study we published in Frontiers in December 2020. So then we will see how we can combine with very easy tools. So like MRI, in this case was on 1.5 Tesla. And we combine this with a small software, then we use it manually. So with the help of engineer and physicist. And then we obtain this fusion imaging. I don't know if you can see a couple of pictures, but then we realized with this simple tool, not easy to use, but we can have a real-time picture or in the fusion of the preoperative imaging, so and the real situation in OR in craniotomy patients. So we did in patients with tumors and in patients they suffered from therapy-resistant epilepsy. So just for example, yes, you can use the next one. So this is so after when we have this combination, so we match and merge the pictures, so the MRI with intraoperative pictures, then we can use like a volume sculpting. These sculptures we obtain with more rotation, and then finally we can have a better view with less artifacts of the superficial aspect of the cortex and of course of the vein. And then we will see in the next picture, for example, this one. So you have a simple imaging here where you can see the venous representation on your left side, then you see the intraoperative representation, and then on the right side you have the fusion of these aspects. And this is important because you don't have the problem with the brain shift. Or if you have is really minimal, this doesn't you don't have a problem during your operation and also in the preoperative planning. Then of course this is the old-fashioned technique, but it's a basis. I think you can, because if you know the anatomy, you will never lost. So if you know the anatomy, and of course you can have the chance to have new and very futuristic tools like the augmented reality, I think that will be a great impact in the neurosurgical practice, but also as Dr. Palmisano said, so I think for the education of the residents, because this is what we want. That is the project we talked with Professor Winkler, with Dr. Umana. This is our project for the future in our lab in Salzburg, because we have a laboratory that Professor Winkler developed this laboratory, a microsurgical neuroanatomy lab. Then I have the honor to continue the tradition, the legacy of Professor Winkler in the lab. And the idea is to have a really lab for microsurgical dissection, microsurgical neuroanatomy, and then we can combine these basis for every neurosurgeon with this new technology, and we can offer, that is our project, our dream, we can offer a fellowship program for people that are interested to learn the microsurgical anatomy in a 3D way, but also with the help of the augmented reality, in order to go to OR with more confidence, because it's not the same. So when you don't have a laboratory education, and then you are alone in OR, you are in the night without navigation or without tools. So, but you have your formation in the lab. So with a lot of tools, even if you are alone in OR, you know what you have to do, and then you will do properly. And that is important not only for us as neurosurgeons, but especially for the patients, because I think once again, for us, it's important the patient outcome. That is our target. That is our goal. So this is what so I want to tell about this project. And please, if Professor Winkler will tell something more, or Dr. Umana, I will be grateful. So.
Maybe just one few words. It's great to have young people like Giuseppe Umana, like Santino Tomasi, with their very great tradition humanistic education, and maybe that's the case why they come from Sicily, but great formation, education, and a great enthusiasm for functional anatomy. And this will be the combination of this fantastic, brand new and very interesting stimulating technology with a very sound knowledge about basic and functional anatomy. I don't talk about the minimum to pass the exam for both examination in every country in Europe or United States or Scandinavia. I know the different systems of neurosurgical training around the world, but I am talking about deep knowledge in anatomy. We are the unique person as neurosurgeon, we see the brain. The neuroradiologist, the neurologist doesn't see the brain. They just see images. We see the brain, and therefore we have the responsibility to know more than other people about brain anatomy, microanatomy. And I'm very happy that I can give this legacy and give this laboratory in Salzburg, because I moved away from there. I'm back to Germany and traveling around the world, but I'm happy to be in the condition to give Santino Tomasi at least the infrastructure of this laboratory from Salzburg. Thank you again, and have a nice evening. Thank you.
Thank you very much, Professor Winkler, and thank you, Ottavio. I think that our technology is amazing and is the future, but this technology must be humble. We always train on cadavers, because all the technology that we can develop cannot reach the feelings that you can have with the cadavers, and also cadavers cannot give you the feelings of the clinical practice. But if we will have the chance to merge the new technology with the traditional cadaver lab dissection, we will have a very unique chance to learn anatomy, to share this knowledge, and to give the legacy to all the colleagues that will come in the future. So thank you all. Dr. Bennett, I don't know if you want to talk a bit.
Yeah, a great presentation, and there's a lot of interest. And I'd like to stress the point that we have the technology to explore the technology, or this technology of webinars and Zoom is a fantastic technology to see what you guys are doing, because we really want to know what you guys are doing. I mean, a lot of people are interesting, and as you said, that's where the future is, and we'd like to explore it with you. So just let us know anything you guys want to televise. Let us know, and thank everyone for coming.
Thank you very much.
Thank you, Professor Bennett.
And maybe just a bit, just a minute. Maybe that there is Circo Pels, that is the CEO of Apocular, that is the system that we are using, that could share some thoughts.
Sure.
Circo, please.
Yeah. Thank you, Giuseppe. No, first of all, very impressive and very good to see all of you. What I saw, indeed, the automatic placement. That is one of the top requests, and I can promise that we deliver a version end of this month for testing. So, and the aim is to have it in 1 minute. So let's see. Especially the accuracy will be quite interesting. And I think what we always said. Now we are happy to deliver the core modules, the core technology, but the innovation, the idea must come from the people who use it, from the surgeon who use it, because they are the best who define it, and it's very motivating to see you all. And I think in one of the next meetings we could also switch between, because you can shared experience over distance, to have the surgeon from Salzburg, from NUHS next to you in Catania. Is it Catania? Yes, I think so.
Yeah.
Perfect. To have next to you and to join the surgery and to do it together. We are the HoloLens.
Yes.
So it's quite interesting. No, thanks a lot. And we are fully supportive of everything you need.
Thanks to you, Circo. And I think that the anatomy lab in Salzburg could be a great opportunity for all us. We are managing to start a cooperation with the Singapore team, but also with the teams in United States and also in Spain. So I think that thanks to the new technology, we can have quick webinars without moving. And also thanks to the hologram, we can have a better understanding of the neuroanatomy. So thank you for your work. Thank you.
Thank you. Thank you, Giuseppe.
Thank you.
Thank you. Thank you. Thank you, Dr.
Great.
Bennett, for this opportunity.
Okay, we'll end the webcast and we'll edit it and hang around to network. Okay. Thanks,
Okay.
Yes.
thanks,
Thank you
everybody.
so much.
Thank you,
Thanks,
Professor
John.
Winkler.
Bye-bye.
Thank you, John.
Thank
Bye.
you so much. Thank you all.
Thank you all.